Good evening, everyone, and welcome to the Leading Clinical AI Interactive Q&A session. I'm Horace, Associate Professor at UNSW Sydney and the Director of the UNSW AI Institute. Most importantly, I'm your academic lead for this year's Learn to Lead extension, Leading Future Technologies. In the previous live session, we had Dr. Sebastian Grayson, and in this particular session, we are pleased to have Associate Professor Blanca Gallego Luxan, who will be answering all your questions on the Leading Clinical AI module. Before I begin, I would like to acknowledge the Gadigal people of the Eora Nation that are the traditional custodians of the land which I'm speaking to you from at UNSW Sydney. I also acknowledge the traditional owners of the lands that we meet on, wherever they may be across the country, and pay our respects to the elders, past, present, and emerging. Today's interactive Q&A session is an opportunity for us to delve a little deeper into the topic of leading clinical AI, and for you to ask any questions you may have regarding this module. But before we get started, a little bit of housekeeping. As this is the final interactive Q&A session, I just want to remind everyone that in order to receive your digital badge, make sure that you complete all video recordings, complete the multiple choice questions for the two modules, and to complete the evaluation survey on the digital tab in the navigator. Once you've completed this task, the relevant section will have a green circle next to it, and if it's not yet the case, complete the circle will be orange. You will receive an email from Credly, the digital badge provider, once your digital badge has been issued. This can take a few days. If you have completed all the course requirements, but have not received your badge by Tuesday, 24th October, please contact us. And most importantly now, thank you to all those who have already submitted questions. We have taken a look at all your questions. I've handpicked the most popular question themes that I feel will benefit from Blanca answering these questions. After this, we'll move on to real-time questions. I highly encourage you to post your questions through this session using the Q&A function in the Zoom application, and we'll try to answer as many as possible in the time that we have. Please note that this particular webinar is recorded and will be posted to the Learn to Lead Navigator platform tomorrow. So let's get started. Welcome, Blanca, and we have several questions which have already been posted. I'll start with three handpicked ones. I'll start with the first one. And this particular question is on the potential obstacles. So the question is, what are the potential obstacles that leaders will face towards AI adoption, and how can leadership help address these concerns?
Thank you, and hello, everybody. So I can answer, well, it's of course many obstacles that we keep on facing and will face in the application of AI in health. As you know, medicine is a very peculiar domain because there are a lot of high stakes with respect to, the impact can impact human lives. So we are very careful about this, as well as it has also high stakes regarding data privacy and other things as compared to other domains. I think I would say that two main obstacles that we tend to underestimate are trust and money. So trust, because we don't only need our systems to be good, but we need the users to perceive them as to be good. So we need the users to trust in the system, the future users. So trust can be divided in different dimensions, but basically you would be asking for questions for your AI system. So you would ask, is my AI system competent? Like, does it do what I said it was going to do? But then you also need to ask the question of, can the AI system share my values, the values of the users in this case? Is it in the user's side? And ultimately, do I like the system? So that means that on top of competence, you need to have charisma. It has to be desirable. And it is desirable when the system is doing things as expected by the users. And that's why, as I was mentioning in my lectures in this module, human-centric design is extremely important. You have to empathize with the user, and you have to put the user at the center of the system. And only then there'll be trust associated with the performance and utility of the system. The other thing that I mentioned is money. Money is also something that sometimes we forget or we leave till the end, but it is very important to have a business model when you are developing AI algorithms and AI tools, I suppose in all industries, but also equally in health and medicine. Because I mean, it's kind of obvious, but the healthcare system is obviously under a lot of stress. There's already very little money, and you need to demonstrate either that you have a cost that can be passed to the consumer, or that you have a cost that it will be eventually not important because of the amount of money that you will be saving down the track. So you need to consider your business model carefully. I don't know if I answered correctly.
No, it's a great answer.
Trust and money, basically, that is my
summary. Before I move on to the second question that we've handpicked, I just had a follow-up question regarding AI adoption. So you do more research, but you interact a lot with practitioners. What are their own attitudes towards AI adoption? Are they keen? Are they concerned? Are they circumspect? Or how did you perceive their attitude towards AI adoption?
And I think there is a mixture of opinions. The first thing that they will ask you if you talk about an AI system would be, how does that help me? How does that help me or my patients? And so you have to have a very clear message about that. I don't think there is distrust in terms of distrust as if that they believe that it's going to cause harm, but I think there is distrust on that, do they believe that it's going to work and that's going to make a difference from some of the clinicians that I work with. But ultimately, if you are going to build any tool, you need to have the leaders, clinical leaders, that are going to be sort of helping you design, develop, and ultimately implement your tool in the clinic, in the real world, obviously. But yeah, I perceive distrust towards will it be good enough rather than distrust towards, it could be harmful.
Great. Let's move on to the second handpicked question. So the second question is that, could you share how humans and machines work best together to mitigate bias?
So there's more research that needs to be done, I think, in this field, but there's evidence that points out to the fact that when humans and AI work together, the performance of the combination of both tends to be better, and also the system tends to be less biased. And there's many reasons for that. So one is that humans and machines approach problems differently, of course. Machines can learn from millions of examples very fast. That's something humans cannot do. But then humans can look at a problem using domain knowledge. They can look at data that is not available for the machine during training. And also they can look at outcomes or that are not those that were originally targeted. So for example, if a machine is being trained to detect pneumonia in X-rays, it will just detect pneumonia in X-rays. But a human can look at an X-ray and detect other things. So I think they have some complementary functions. Also, another thing that is very important when you consider the convergence of human and machine intelligence is the concept of uncertainty. So you want machines to be able to, so you consider a machine learning algorithm to be good when for the situations in which it predicts incorrectly, the uncertainty is high. Basically, you don't want your algorithm to be certain about wrong predictions. That means that if the algorithm is well designed, there will be high uncertainty for certain cases, which is a sign that the algorithm, is not capable of providing a prediction, and then should defer to a human. So there's another way where where human and machines can interact in a useful way. So there are some algorithms proposed that are called learning to defer, where the machine learning algorithm is saying, this is, I'm sure, this is a positive case, this is a negative case, and for these ones, I don't know, and should be deferred to a human. And so that in that way, you can use AI algorithms as triage or referral systems, particularly in situations where there is a lot of scarcity in resources.
Good. Great. Speaking of, the question was focused on mitigating bias. So the third question is also somewhat related. So it asks about ethical considerations. So the question is, how can you maintain a patient-centric approach and ethical considerations when integrating AI into healthcare practices, ensuring that the technology benefits the patient's well-being?
Yeah, so this is a current area of research as well. I don't have answers to these questions, but I am aware that the Australian government proposed 8 ethical principles and for AI, and they are, well, I'm not going to list them, but they regard to privacy and security and fairness and being a safety and robustness, and the fact that they had to be wellness, they had to be beneficial for everybody, etc. And so things that we expect, AI systems to comply with. But the problem that we have with these current ethical principles is that they are too general. And so what we need to do is we need to convert these ethical principles into actionable, into things that we can action upon, in order to then go about trying to integrate these principles with the AI technologies. And this is something that has not been done yet.
Mm-hmm.
But there is things that could be done. For example, you could have tools that audit for bias before the implementation of an algorithm, and then suggest mitigation strategies. This is something that is currently not done. Even if you go for, if you submit a software as a medical device to the TGA is going to look at measures of perform predictive performance, but it's not going to have any test to see if the algorithm is biased, right? So perhaps some of these tests should be included in current considerations for, software as a medical device, for example. So basically my answer is we are very far to do this yet. There are certain things that have been proposed, and we are all trying to work towards doing it. But yeah, it's not achieved yet. We are far from it.
Yeah, your comment connects well with the module by Sebastian as well. He also focused on false positives, false negatives, and importance of fairness. One thing I'll add here before we move on to the live session is that this issue that you pointed on about having precise definitions or very precise versions of these notions such as fairness is such a tricky issue that there are even papers which talk about 21 different definitions of fairness, right? So
Right.
it's not clear which fairness definition is the right one for different settings. Anyway, I think we've had a great start with the 3 hand-picked questions, but now we're starting to get questions in the live Q&A part. So just to encourage you all, please keep those questions coming. I'll start with one question which is posed by Matt. So Matt says that I'm fascinated by the idea of using digital twins to generate synthetic data that can be used to train models. How new is this concept? What do we know? What do we need to know about the limitations of this approach? And what are the critical aspects to manage well for it to be successful? So it's about using digital twins to generate.
Yes. Yeah, I'm also fascinated by it. I am not an expert on digital twin technology, so I don't think I can, describe the nuances and other things. I became aware of this concept a long time ago, actually, maybe 15 years ago, a long time ago. There was a company called Archimedes in California that was building this sort of digital twins and of humans, and what they were doing were then trying to demonstrate that they work by comparing the results of the findings of by simulating a clinical trial of drugs in these virtual twins and comparing it to the results of randomized control trials. This was, many years ago, and they were mostly focusing on, so they mostly simulating, I think, some parts of the heart or the metabolic system. I can't remember. So the idea is pretty old. From a methodological point of view, it's very beautiful because it combines AI with more mechanistic modeling, which is like what I used to do when I used to be a climate scientist. And when you run a climate model to predict climate or to predict weather, you basically have some knowledge represented in the form of equations, and then you integrate these equations on time to simulate different scenarios. Some of the virtual twin technology that we have kind of combines the mechanistic, more traditional modeling that we used in physics with the AI techniques, newer AI techniques. But I couldn't tell you about nuances and was the latest. I didn't follow yet, although I'm actually writing a systematic review about it. So maybe you ask me, send me an email next month and I'll tell you more. But yeah, I find it fascinating. I'm assuming that probably getting data is probably going to be a problem, because if you are trying to represent the human physiognomy, then you probably need to have data at different scales, from the genotype to the phenotype. So I'm assuming getting the right data is going to be, enough data is probably going to be a challenge. Obviously, attempting to simulate the whole human body is also going to be a challenge. But yeah, it's a fascinating area of research, I think.
Great. Let's move on to the next question. The next question is from Neil. Neil is asking about, he says, you talk about trust, but how exactly can CEOs and the management teams build trust around AI processes? So it's a bit similar to your first question that we looked at, but if you could go in more detail on building trust around AI processes.
I'm not sure how to answer this. So the only thing I can tell you is that often researchers that do develop AI algorithms, they focus a lot on the predictive performance of the algorithm, and they think that that's kind of showing that is sort of enough. But often what you need to do is not to show that it's good or that it can, of course, you need to go and show that it can save many lives, that is, has, ultimately you will need to show that it has impact in patient outcomes or processes of care. But I think there is a human component there, which goes beyond technology, which is the fact that it has to be perceived as what it is and not just be what it is. And I think that means that you have to involve the users and the decision makers more actively than you would do if you just do research. This is kind of my take on what I have observed. And another thing when it comes to making something desirable is that you need to understand very well how people currently do things and how people actually would like to interact with the system, because that can sort of make or break the adoption of a technology.
Blanca, you mentioned about stakeholders. I was wondering, when you're trying to get or elicit priorities from stakeholders, are there situations where the priorities might conflict with each other? If that's the case, how do medical practitioners and researchers deal with the situation?
I don't think I have found in situations where there is sort of real conflict, but there is when you gather a group of senior clinicians, particularly very senior clinicians in one room, there's always going to be different opinions, very strong different opinions, and you need to be anticipate that that's going to happen and then sort of deal with it. But can't remember a situation where there's a true conflict of interest between two parties.
I see. Okay, let's move on to the next one. Syed has a question. In your expert opinion, throughout your experience, what is the potential of AI in top 5 healthcare areas?
So I think definitely image processing is the area where it's gonna be like the easy pick in a way, because the deep learning algorithms we have are so good at processing images, and processing images is such a time-consuming, resource-consuming, sometimes burdensome task, like these things that I was again mentioning in the lecture, like aligning the images, making sure that the image is high resolution, high quality. And, there's a lot of analysis of images that is painful, that can be automated. And I think definitely AI is going to play a very important role. This is all across diseases. And probably as well as we move towards video, I think that may lead to as well a lot of impact from AI. Another area that I think, of course, comes with ChatGPT and the large language models is the whole idea of basically summarizing patient notes, querying patient, medical records, searching for things in the record, the automation of billing codes, or sort of discharge codes, creating discharge summaries, possibly even the idea of how do you capture the record. You could capture the record using AI. So this is, again, another area that I think is going to explode now that we have the power of large language models, which is relatively new.
I would agree with that as well, because at UNSW AI, we often try to match problems with problem solvers, and often if it's a medical problem, it's going to the image processing group, because that's in high demand.
Yes.
All right. Okay. So the next question is by Julie. Julie asks, what leadership qualities are required to foster a culture of continuous learning and adaptation to new technologies such as AI?
But that's a difficult question for me. I think that one thing that I find valuable is being sort of open to multidisciplinary teams, so being open to listen to the opinions of others and adapt to other fields, because the field of AI medicine is just, so it's, as you can see, it's not just AI, and it's not just medicine, but then you have the whole area of ethics and law and engineering, and then there is data engineering, and there is data analysis, business intelligence. So there's many aspects that can be part of an AI team, of a team that creates and implements AI in medicine. So I think understanding that that is very wide is important. I don't know. I think in other respects, I don't think it's different from being a leader in any other field. Generally, people who are optimistic, that's important. Otherwise, you don't last, because it's hard. Resilience, believing in something and going for it, that's just kind of typical leadership, taking responsibility, typical leadership skills.
Good. Speaking of tough questions, there's another one. It's by Hugh, who asks, how do we at UNSW/Australia place or progress in this AI medical field against the world, China in particular?
Very important question. Yeah, very relevant. I don't know. I agree with the person who raised the question that is very difficult whenever you are in this, particularly in technology, not just in medicine, in all technology. Probably you know as well, Harris. The difficulties of trying to make a difference in technology when you have companies from the US and China with much more money and much more people and much more power. I think maybe in Australia, maybe the competitive advantages we could have in medicine is that the healthcare system, of course, is very specific to the Australian system, very different from the US and the Chinese one. So that could be an advantage for people like us. But yet, in general, we are disadvantaged. There's much less investment, much less money, and much less people and talent. I don't know, Harris, do you have an opinion on this?
Well, you mentioned money as one of the first obstacles, right? So that's definitely we need more investment for sure. But I agree with you that just in terms of general trends, I think China is on a very upward trend towards like dominating in all these scientific fields, especially in my own research conferences. The number of papers or percentage of papers from China is definitely increasing significantly. Yeah.
Yeah, I mean, it's also a tendency of when it comes to startups, for example, there is a tendency from, say, New South Wales Health, just to put you an example, if they're going to purchase some software, there's a tendency for them to purchase software from big companies because they don't want risk, right? So that is also a factor to take into account when you're trying to develop and implement software in this country. Yeah.
Okay, let's move on to the next one. I'm glad that we do have several questions coming in. So Julian has it's again a question on biases and representation. So the question is, AI may replicate and reproduce existing assumptions and biases in minority groups if these biases are already embedded in the data sets. How then can AI systems create fairness and overcome these inequalities and prejudices? Who should be leading or regulating this?
Yes. So yes, this is correct. If you train your data with your models with data that has bias, then you're gonna just replicate the bias. And this is actually really dangerous because you are systematically replicating the bias, which is worse than some ad hoc people being biased. If it's a machine, it's just a systematic bias. That's very bad. So the recommendations are, well, look at your data when you're training your model and make sure that you are not, for example, one of the ways in which you replicate bias is when you use in health data, is when you train your model using data that is a proxy for a clinical problem and that is associated with a behavior, say behaviors of doctors. So you need to try to avoid this sort of proxy data when you train your model and try to go more towards the raw biological information when possible. Of course, you need to try, another way to try to improve it is to make sure that you have representative samples so that you have, people with different ethnicities. Another way that you could maybe address this is with the idea that I was mentioning before of uncertainty. So if you are training your model with, say we are looking at the example that I was mentioning in the lecture, where you have a system to look at skin diseases, right? And it's trained mostly with people with white skin. You're going to have a bias in that the performance for people with black skin is going to be poor. But one way of addressing this, apart from the fact that you should try to then have a more representative sample, obviously, for training, is that if your model is high quality and you have enough data as well, and you are displaying uncertainty properly, then for these people who may not, with no, where the skin is not white and the system may perform worse, the A system itself should be able to tell you, I don't know, I don't have enough data. And so that at least guarantees you that it's not giving you the wrong answer for these cases. So there's many ways in which you can look at your data and look at the performance of your model at the end by subgroups to make sure that there is not a very strong difference between the performance for some groups or the others. Who should regulate? This is really not my area of expertise either. I don't know. I mean, I know there are different legislative frameworks that look into, anti-discrimination laws, etc. But I don't know in the context of this type of
I would just add that recently, just a couple of months back, the EU Act on AI, fairness in AI came out, and that's probably leading the way in terms of many countries are looking at this piece of proposed legislation, and they're trying to see how they could tweak it or change it for their particular country's context.
Yeah, but who's gonna test it at the end? Do you think that there should be then some sort of accreditation? Say, I don't know.
Yeah, lots of questions around standards.
Yeah, I think at the moment we are a bit not quite there.
Yeah.
Because even as you were saying, even transforming these principles of fairness into something more actionable and tangible is still not done. Yeah.
Okay, so Jennifer has a question. Jennifer asks, do you have any thoughts on uses of AI to benefit the healthcare system at a higher level? I'm thinking about healthcare system operations and functions on larger scale across a state or nation, for example, rather than specific patient applications.
So there is a lot of AI tools proposed, well, a lot no, but there is activity of AI tools proposed for administrators, as well as AI tools proposed for public health, for example, in the case of the COVID pandemic. So there is activity elsewhere. And I think in terms of AI for more administrative or operational tasks is also relatively easy compared to AI for sort of clinical tasks. But yes, there's many things that you could be doing in terms of scheduling and planning. Some people, as we were discussing before, the digital twins as humans, there's also the digital twins idea as organizations. So you could have a digital twin of a hospital or a digital twin of a health system, and you could potentially run experiments, different scenarios to see, what things would or would not work from the point of view of public health. So there's a lot of activity in the area. It's not something that I have worked with, but yes, there is, and I think it may be actually easier to implement in a way than some of the more medical tasks.
Right. Nicole has a question on case studies involving clinical AI, whether there are any that have had severe yet unexpected consequences in the medical industry. I'm not sure if it's negative consequences or extremely positive ones, but that's the first part. And the second part is, what were the resulting consequences of that case, and how did AI clinicians improve their model from there? So I'm assuming it's negative consequences.
Yeah, so I don't know of any case in Australia, but I know that when people talk about, and it is also something that I mentioned in my lecture, when people talk about the concept of data shifts, and this is the sort of post-implementation bias that happens when you implement an algorithm that appeared to be working very well with, retrospectively in your sort of lab. But then when you implement it, it stops working appropriately for different reasons because, and I was mentioning different, changes in technology, like, they change the scans in the hospital or they, a typical example, they introduce a new technology. And so you are predicting outcomes, for example, but the outcomes that you are predicting the risk of something, say, or some outcome. But when you train your model, that particular health technology didn't exist. And then when you put it in the actual real world and this new technology comes along, then your prediction is no longer, valid, etc. So there's many examples. And I think in my lectures, I put as a reference a paper which is very interesting that has a summary of all these different ways in which you can encounter this post-implementation bias that leads to these problems. I believe one of the examples, and so you can refer to it and otherwise send me an email and I'll send you a link to the paper. But I remember one of the examples happened during COVID in the US. They had an algorithm to predict, I think, sepsis. Or early identification of sepsis. And during COVID, the algorithm stopped working properly because the relationships between the predictors and the outcomes changed with this COVID population. So yes, these cases, and that algorithm was actually removed from the system when they realized. And there's more cases. Send me a message and I'll send you this paper that has examples. But I don't know in Australia, I'm not aware. In Australia, we have not implemented that much compared to the US, or other countries.
Okay. Michael has a question about beyond image analysis. Is there potential to take all sorts of other chemistry and biological data, antibodies, metabolic data, genomics data, and so on, from a patient to identify issues?
Yes, it is possible, but I think this answer is kind of similar to what I was talking when I was talking about virtual twins. Mm-hmm. It's hard to have access to biological data and molecular data. And some relevant data is hard to get from patients. So one of the problems that we face in medicine, I find, and it's improving, but is still the case, is that it's easy to get big, shallow data, and it's easy to get small, deep data. So you can have, the full genome or whatever for some small number of patients, and you can have, huge administrative data sets of hospitalizations linked with death or ED admissions, etc. But what you actually want is deep and wide, and that's often it's very hard to find. Plus, of course, you can imagine the complexity of understanding, of going across scales, right, from the molecular scale to the sort of environmental, in determinants of health, diets, exercise is such a huge area, right? To how do you go from genes to, how do you incorporate the influence of genes together with the influence of what you eat and what you exercise and everything in between. It's extremely complex, but it's extremely exciting. I think it's very interesting if one day we can have a better understanding of this sort of a more holistic view of the human body and how we interact with the environment, but still very far away. I mean,
like AI-empowered personalized medicine would have applications as well, right? Using all kinds of data, multinomics data to have personalized medicine or personalized healthcare would be one application.
Yeah, but one of the things that I also mentioned in my lectures that I've noticed when it comes to personalized medicine, with the exception of, some situations, particularly in cancer treatment, where, there's a clear link between just one or two genes and sort of the effect of treatment, is that the more personalized you want to go, the more data you need, because to do statistics, you need numbers. But if you go too personalized, the more personalized you go, the less numbers you have. So I think precision medicine has not given us what we thought it was going to give us yet. And I think we are going to need deep, wide data for that we still not quite have.
Okay, so one message is that we need wide and deep data.
I think so.
Okay, I think we're running out of time, so we'll take one more question. So this particular question is from Fillmore. There are indications that people are now using AI to address their own legal issues. Do you see people using AI to increasingly diagnose their own medical issues? What are the clinical implications?
I have not seen that, but then I don't work in the consumer AI health space. I'm assuming you refer to wearables and people then self-diagnosing based on, all these wearables and apps that they buy. I'm sure it's increasing, but unfortunately, it's not I'm not an expert on it, so I can't quite say it, but I can imagine the combination of that and ChatGPT could be pretty interesting in terms of self-diagnosis. But sorry, it's not my expertise, I can't say.
Do you have any concerns about medical practitioners using ChatGPT to consider writing scripts and all? I guess it's highly dangerous, right?
I don't know. I mean, I think ChatGPT is, I'm sure it's going to improve, but I think these large language models in general are pretty good at summarizing or querying knowledge that already exists. So if you use it just to, recall existing knowledge or summarize existing knowledge, I think that is pretty safe to me. And I think the problem is if you encounter things that are not being, that the algorithm has not seen before.
Unless there is some source which is not correct, right? That might be an issue.
Well, yeah, that's of course as well. Yes. Yes, you're right.
Great, plenty of questions and very insightful answers. I'm afraid we're running out of time. We still have a few questions which we can take offline. I think it's time for us to wrap up. I'd like to thank Blanca for answering so many questions, many rapid questions, and for the audience for asking such engaging and thoughtful questions. I hope you enjoyed this session as much as both Blanca and I have. As you know, this is the last Q&A session as part of the Learn to Lead extension course for 2023. I hope you have enjoyed the course and have come away with some inspiration and practical steps for leading future technologies. Thank you. Stay curious and good evening.
Thank you.